Hi, everyone, and welcome. I'm Shilpa Venkatachalam, Chief Patient-Centered Research Operations and Ethical Oversight Officer at the Global Healthy Living Foundation. Thank you for joining us for this important conversation, part of our CDC initiative focused on improving awareness, detection, and management of polymyalgia rheumatica, commonly known as PMR. PMR is a condition that's often under-recognized, especially in primary care and public health settings. We know it affects older adults, and when diagnosed and managed appropriately, outcomes can be favorable. But we also know that diagnosis isn't always straightforward, and surveillance over time is even less so. There's currently no gold standard test for PMR, and disease activity doesn't always map neatly to traditional inflammatory markers like ESR and CRP. Patients may feel better before their labs normalize or vice versa. Now, add to that the lack of universally accepted tools for long-term monitoring, and we're left with a serious gap in care. So today, we want to unpack the complexities of surveillance in PMR, what it looks like, what's missing, and what tools clinicians need to effectively track disease over time. Before we dive in, we'd love to know where everyone is tuning in from. Please don't forget to use the chat feature and let us know where you're joining us from. And just a very quick note to add on the Q&A. We encourage you to send us your questions at any point during the webinar using the chat or Q&A box. We want this webinar to be interactive. We're going to try and answer as many questions as we can during our conversation. So let's dive in. I'm thrilled to be joined today by two experts I deeply admire and have had the pleasure of working with. Dr. Len Calabrese from Cleveland Clinic and Dr. Jeff Curtis from the University of Alabama at Birmingham. A very warm welcome to the both of you.
Hey, it's our pleasure.
Thank you.
So, Len, may I request you to introduce yourself to our audience?
I'm Len Calabrese. I'm a professor of medicine at the Cleveland Clinic Lerner College of Medicine and vice chair of rheumatology at the Cleveland Clinic, and very happy to be here.
Thanks, Len. And can you share your thoughts on why surveillance is such a critical piece of PMR care, especially given the chronic and relapsing nature of the condition?
Well, surveillance is really a broad term. Surveillance, to me, it covers not only the identification of the disease, which I think is the major hurdle in the care pathway of timely and accurate diagnosis, but it also implies coming into a care pathway that monitors patients, because this is a disease that more often than not requires therapy, often extending more than 1 or 2 or even 3 or more years. So finding the right clinician for an accurate diagnosis, starting on appropriate therapy, and then being monitored not only for efficacy but toxicity are core concepts of PMR.
Great. Thank you so much. And, talking about monitoring and care pathways, Jeff, coming to you, and again, I'll request the same of you. If you could maybe start off by introducing yourself to our audience and perhaps discuss from your clinical experience, what are some of the downstream consequences when PMR isn't well monitored?
Sure. I'm Jeff Curtis. I'm professor of medicine, epidemiology, and computer science at the University of Alabama at Birmingham in Birmingham, Alabama. And I'm in the Division of Clinical Immunology and Rheumatology. I think this is a really important topic because surveillance for polymyalgia rheumatica or PMR can be rather insidious, and if not done well, has a lot of bad consequences that sometimes can be a little bit hidden and on the front end may not be recognized. So Len spoke about surveillance for the disease. Do people have the disease? Is it active? Is it still active? There's that kind of surveillance. But I think that what often goes under-recognized is the surveillance for toxicities or side effects. I think most people who are familiar with this condition know that glucocorticoids or steroids like prednisone or Medrol, as kind of the more typical steroids we might use in the United States, those are generally the mainstays of therapy. Most people are going to end up on those either as first line and certainly along the way as part of their journey. And so I would suggest that surveillance needs to be surveillance for glucocorticoid or steroid related side effects. There's a number of ways that we can do that, but they're very intrinsically related to all the bad things that steroids do, and that sometimes doesn't get recognized. To take an example of what one kind of surveillance, surveillance for osteoporosis or bone health. Steroids like prednisone are good for a lot of things and certainly are helpful in the treatment for most patients with PMR, but it's one of those things that the clinician may think at the outset of the disease, oh, I'm only going to have this patient on prednisone or other steroids for 3 or maybe 6 months at worst. And then, a year and a half, 2 years down the road, they realize, oh, they've pretty much been on some dose of prednisone nearly continuously for this entire time. Those bones have been thinned, and it is a whole lot tougher to regain lost bone density and bone strength after it's gone than it is to try to protect it on the front end. So surveillance for bone health and some of the other steroid-related toxicities that we can talk about is another important aspect of managing this disease.
Thank you both for those insights. What you both shared underscores the important role clinicians play in monitoring and managing PMR. To build on this discussion, we've put together a brief 4-question quick poll for physicians and healthcare providers in our audience. Your input will really help us better understand current practices and challenges in PMR care and guide future educational efforts. So to that end, we're inviting you to take this short 4-question survey during the session. Your perspective is invaluable in helping us identify where PMR surveillance falls short and how we can work with regulatory bodies to address those gaps through future research. So please scan the QR code that just appeared on your screen. You can also type the link you see on the screen at the moment, and we're dropping the link in the chat as well now. Responses will, of course, remain anonymous, but once you've taken the survey, you'll be able to see how other people have responded, and we will address the questions of this survey throughout the webinar. So I want to move now to challenges in monitoring. Len, let me come to you. What do you see as the main limitations in how we currently assess disease activity for PMR?
Yeah, this is really an interesting and important question. And, at first blush, for those of us that have taken care of a lot of polymyalgia rheumatica, in many patients, it is driven by their reported observations, and it's very clear-cut when a patient goes from profound pain and early morning stiffness to having it disappear. Unfortunately, that's really not the clinical course of all patients who have this condition. And I think it's confounded by the fact that this occurs in a population of patients that is an older age group. They have a number often of chronic musculoskeletal ailments, osteoarthritis, periarthritis of the shoulder, varying aches and pains that unfortunately are common as we age. And thus, when we start our therapy, get an initial response, if it's subtotal and patients still have some aches and pains, it depends on the powers of observation of the patient and the skill of the clinician to sort this out. And unfortunately, sometimes this is more difficult than we would like to encounter. I'm not going to talk about biomarkers now, but we do have biomarkers that are helpful but are imperfect, including SED rate and CRP, and this may be influenced by biologic therapies, et cetera. But I'll just stick to the clinical aspects.
Great. Thank you, Len. So talking about limitations then, Jeff, how would you say these limitations that Len just touched upon show up in primary care? especially when it comes to managing tapering of steroids, when to refer a patient and to whom, for example?
Sure. Len brought up one of the most vexing aspects of this disease, which is it active? And if it's not, should I try to taper steroids now? And I agree with him that conflating active PMR symptoms with all the other reasons that may cause somewhat similar or mimicking symptoms or be reasons that somebody feels pain or stiffness or fatigue or has osteoarthritis or kind of general wear and tear kinds of routine pains. Distinguishing that from the inflammatory aspects of PMR can be pretty challenging. Lots of experience doing that, but then seizing on some of the symptoms to say, is this really the PMR, or is in fact this something else that we need to consider totally separately? And unfortunately, that's tough to do in a 12 or 15-minute office visit. So that's not a limitation of only primary care. I think that's probably everybody that sees patients where you're trying to fit sometimes complex disease with lots of different kinds of symptoms into a pretty short time frame to figure out, is the PMR active? But to answer your question, some of the implications of when that goes awry manifest themselves in not knowing whether or how to taper steroids. And here is where I think some of the science and even some of the trials and conventions in our field for this disease have not been very helpful. And let me tell you what I mean by that. There's not really a right way to taper steroids. There are protocols that have been deployed in clinical trials. I don't get the sense that very many people follow them as a matter of course. And there's not a right way to taper steroids. I will tell patients, though, there probably are wrong ways, and that's to go way too fast. But the implications are that if I'm not certain if I should taper steroids, and I'm really not certain the best way to do it, should I try to taper over 3 or 6 months, or, how many times should I try to taper and that doesn't go well before I need to add a steroid sparing agent? If you're comfortable using one of those, perhaps methotrexate or leflunomide or one of the newer biologics like IL-6 therapy, or should I refer to somebody who is comfortable with those therapies if that's not in the armamentarium of the primary care clinician? I think those are some of the more challenging aspects of the disease. And this is where the art of medicine comes into play. But based upon some large-scale population data, there may be too much art and not enough science where people just get stuck on steroids for a whole lot more months than is warranted, when there really are some credible next steps to try to save people from long-term toxicities of steroids that need to be harnessed earlier in the disease.
Great. So this is really interesting. We've talked about steroids tapering. We've talked about the role of surveillance. I want to bring into this conversation about the topic of biomarkers here and the role that they play. So let me come back to you, Len. Are there any emerging biomarkers or imaging approaches you're watching closely that might offer more objective ways to track PMR over time?
There is a utility of traditional biomarkers of acute phase reactants. And, I would start with CRP, which is a direct measurement of the acute phase. Sedimentation rate is more difficult to interpret. It's an indirect measurement of inflammation. In the ideal situation, when a patient is started on glucocorticoid therapy and the CRP is elevated, palpably to begin with, we'd like to see this fall, well within the normal range. There are patients that start with relatively low CRPs, and this actually brings up a question of ongoing debate. What is a normal CRP? Is it 0.5, 0.6, 1 milligram percent, et cetera? But we'd like to see it fall into the normal range. When it's in sync with patient symptoms, we're comforted and the patients are comforted. But, at times this is not as seamless as I'm portraying, but I think it's a valuable tool. I actually don't even use the sedimentation rate in my practice of this other than on initial screening, because I think it adds some additional information. There are efforts to assess disease activity by imaging but this is now resource intensive and cost intensive, and I don't think, with the exception of whether there's an isolated, continuous symptom in a local regional area, to dive deep into that. I don't think that they're used routinely in practice. Jeff, what do you say?
So I would agree, and as you said, it's cost and resource intensive, particularly longitudinally, where I think the biggest conundrum lies. So there's what you might need to do to establish a disease, where I think there may be a role for advanced imaging, perhaps MRI or some biomarkers, but I think trending some of those things, getting serial MRIs is just going to be impractical, and probably insurance is not going to be keen on allowing us to do that as a monitoring strategy over time.
Great. And so, when we talk about the role of biomarkers, we're really talking about the data that helps you as physicians to monitor and track PMR over time. Jeff, let me start with you on patient-reported outcomes. What do you think is the role of patient-reported outcomes in surveillance? For example, can they help fill in some of the gaps when labs or clinical signs fall short?
I think they can, and I think it's very helpful if patients can track that and help us as their clinicians to trend over time. So the things that patients care about that often are influenced by the disease that we can trend longitudinally include fatigue and pain, and how much pain affects function. Those kinds of measures I find very useful. Len mentioned acute phase reactants like C-reactive protein or sed rate. So the PRO, though, data, the patient-reported outcome data, I think is a helpful complement, particularly if you can get people started doing that on a regular cadence from the beginning of the disease, because then you can trend that over time, and then as the patient is improving, you have a sense, because you have something to monitor and something to measure. It's hard to improve something that you're not measuring, and if there's ambiguity about what's worsened, or are you really different, or you just not really remember since 3 to 6 months since I last saw you, how much better or worse are you? Have you had flares? If you're collecting weekly or even a couple times a month patient-reported outcome data, I think that can be very helpful to augment some of the disease journey information that the doctor and the patient need to help manage this best.
I'd like to just embellish on that a bit, and Jeff knows that I'm a big proponent of patient-reported outcomes, and we collect them routinely on all of our patients in our clinic. I think that PMR is still a disease where deep listening and the art of medicine play a major role. If I'm looking at a pain scale, a PROMIS pain and pain interference, and I can watch it go up or down, that doesn't immediately tell me that this is tied to their polymyalgia rheumatica. And, there are questions that I routinely use because I am particularly interested in those pain signals that are accentuated in the morning, early morning stiffness, which is a highly sensitive yet nonspecific marker in polymyalgia rheumatica. So the patient may have a blip on his pain, but this may be because he hurt his back, raking because he was doing so well or something. So I think that using this in consort, particularly when there's discordance between what you think is going on and what the patient's going on, is just a safety check and an important part of using PROs in practice.
So you both make some really great points there. We're talking here essentially about triangulating different pieces of information and data. I'm coming here now toward the last section, Jeff and Len, where we're going to be talking about guidelines and tools, and really talking now to regulatory bodies, policy folks, etc. Thinking of that, as clinicians, what are some of the tools outside of rheumatology that you think are needed to support consistent and accurate surveillance? So, it's a sort of a big question to ask, I realize, I know, but just thinking about the broader landscape, what do you think is needed for us to better surveillance in this area?
I'm big on the safety side of things. So I think there's the devil you know and the devil you don't. And people are comfortable with prednisone, but it does a ton of bad things, as I think we all know. So I mentioned thinning of the bones or causing osteoporosis, resulting in fractures. That's the one that I think looms large in my mind. But it worsens aspects of the metabolic syndrome, so diabetes or pre-diabetes, aspects of cholesterol and lipid management, something that needs to be looked at carefully. It increases blood pressure and fluid retention, cataracts, glaucoma for people with diabetes or preconditions, looking at blood sugars or hemoglobin A1C. So I think all of those tools need to be thought about. So that's one aspect of both the monitoring and the tool set that a clinician and patient need to be thinking about in terms of the long-term steroid-related toxicities, and I would put that in one bucket. But then I would also be quick to recognize that there are some newer therapies that we can speak to that are steroid sparing, and if they're effective to get people off prednisone, sometimes patients may be skittish about using them. But I think sometimes the long-term toxicities and the safety of staying on 7.5 or 10 milligrams of prednisone month after month, year after year for somebody in their 60s or 70s, like that has its own risks, and sometimes those are under-recognized and undervalued. So I think the aspects of shared decision-making and those long-term steroid side effects need to be put as an explicit risk on the table as we're thinking about some of the new therapies that we might offer to patients if they're not doing well on glucocorticoids by themselves.
I agree with all of that. And I would like to add, in terms of needs with regard to this disease, which is, among the most common inflammatory mediated diseases that there is, and particularly in the vulnerable aging population. In reality, the majority of patients who develop this don't wind up initially at a rheumatologist. They're seeing their primary care or geriatrician or other practitioner. And I think that until relatively recently, this disease has largely been off the radar for many non-rheumatologists. And I say this just because this is a reality that we've discussed with many primary care physicians. I think that there's a gap in both declarative knowledge about this condition, particularly in the last few years with, great advances in therapies that Jeff's already mentioned, biologic therapies that can be steroid sparing, as well as imaging that need to be more broadly disseminated. I also think that there is a gap in procedural knowledge among many practitioners who don't see this for a living, such as primary care physicians. The differential diagnosis of PMR is quite broad, and sometimes it's a very straightforward diagnosis, classical, responding to glucocorticoids. But there are conditions within the differential diagnosis that are what I call the must rule outs: infection, malignancy, and misdiagnosing these can be cataclysmic. So I would like to see polymyalgia rheumatica become more widely discussed interprofessionally among primary care physicians, rehab physicians, and rheumatologists. I also think that guidelines that are interprofessional would be very helpful to move forward. So collectively, I think that the approach to PMR is a group effort.
Wonderful. Thank you so much, Len. Those were some really insightful points. And, talking about longitudinal tracking, I'd like to draw the attention of our audience to our app and patient research registry called Patient Spot. We'll drop the link for you all in the chat box. This is an app that is used by people across the country and globally, people living with chronic diseases, to monitor and track their symptoms and their disease. Moving on. Len and Jeff, last question, unfortunately, for the webinar. And I was just thinking about this initiative that is funded by the CDC, who we're very grateful to. as a public health initiative. Now, thinking about the future, what systems can we build that can make shared decision-making and longitudinal tracking for disease better?
This is a tough one. If we're talking about healthcare systems or information technology systems to support shared decision making, so that's never an easy thing. And a single clinician in their clinic, busy seeing patients, is going to have a tough time doing that without a lot of help and support. I think there's a couple aspects, though, that are probably themes that we could touch on. The first is, I think, having some sense about guidelines or insights based on evidence. How long should this patient be on steroids before I need to move on? And I can tell you from working with a lot of real-world data in this disease, there is dramatic variability as to how long people are on steroids at some dose that's not trivial before they have a steroid-sparing agent added, before they get referred to a provider that is comfortable with that, ranging anywhere from 3 to 6 months, probably on the short side, to frankly years, and they never get on a steroid-sparing agent. They just live on steroids for this disease. So I think having some sense, based on evidence ideally, and then protocolizing that could be in the form of clinical decision support systems within one's EHR. I think honestly, patient education as a component of that, like you shouldn't be on steroids for more than a year for this disease at doses of 5-10 milligrams plus without starting to have at least the conversation. Maybe let's move on to the next thing, or if a referral is in order, great. But I think helping standardize that and clinical decision support within an EHR or protocols or pathways can be very helpful to rein in some of the inappropriate variability in how patients get treated and end up stuck on way too much steroids for too long.
That was great. Thanks, Jeff. Len, anything to add to that?
No, I agree with Jeff, and I look forward to, EMR assistance, particularly as AI tools are interwoven into our EMR to do exactly what he said. There could easily be alerts for persistence of glucocorticoids or other comorbidities that may, assist clinicians, non-rheumatologists and rheumatologists alike, to start thinking about alternative methods of management.
Great, fantastic. Thank you so much for that really insightful discussion. We're going to be moving on to the question and answer Q&A session. So once again, Jeff and Len, thank you so much for this discussion. I want to move now to our audience and thank them for sending in questions in the chat during this conversation. I know we've received a bunch of questions upon webinar registration. So thank you for sending those in as well. Now, we've had to prioritize a few questions, which we'll discuss now with our panelists. So first question, and these are questions several people have asked. Are there any early warning signs before symptoms fully flare that patients or clinicians can watch for to catch PMR relapse sooner? So we're talking now about PMR relapse here.
This is a good question. I think that in general, patients who present with PMR and are treated effectively with PMR and then relapse with PMR often follow a somewhat similar course. If their presentation was, largely upper extremity, cervical shoulder with early morning stiffness, that's often a harbinger of things relapsing. On the other hand, from time to time, this disease has the capacity to involve, widespread areas of the musculoskeletal system, and also may be associated with constitutional symptoms, as Jeff has mentioned, fatigue, and I'll again come back to early morning accentuation, which I like to question about. And then, While this is uncommon to develop complications of giant cell arteritis in well-treated polymyalgia rheumatica patients, we still are cautious about this and talking to people about symptoms of head and neck ischemia is just part of proactive surveillance.
Thanks, Len. Really great points there. Jeff, any thoughts you want to add to Len's?
Yeah, I would agree with everything that he said, and I think having that conversation with the patient to illustrate to the extent that you as the clinician are comfortable with it and as it resonates with the patient, here are the things that I believe are your PMR symptoms, and then here are the things that maybe aren't. This is your diabetic neuropathy or your mechanical low back pain because you have a disc herniated. These are things that are probably not your PMR, so that in the future, if your back gets a whole lot worse and you have shooting pain down your right leg, that's probably not your PMR. Because again, to patients, if they know things hurt, but it may be just very blurry in their heads. So to the extent that imaging or localizing symptoms or certain body regions might be a little bit more specific for PMR, and as Len said, I also place great stock on inflammatory symptoms, morning stiffness, night pain, rest pain, pain that improves with activity as opposed to worsening, which is kind of the opposite of mechanical type problems or osteoarthritis. If you and the patient can have a conversation, these are the symptoms that I think are more likely to be your PMR, then when those things worsen or come back, that can be very helpful as opposed to some other unrelated condition that might just get blurred with PMR, and then people just throw more steroids at it when, in fact, that's maybe not the right thing to be treating. So trying to make those symptoms as specific as possible on the front end can be very helpful so patients can recognize this is probably my PMR versus this is something else related to some other health condition.
Great. So you've already anticipated actually the next question here when you talked about PMR symptoms versus symptoms that might be coming from something else. And given that many PMR patients are older and may have multiple health conditions, comorbidities, how or what would you say is the best way to balance PMR surveillance with monitoring for other diseases without really overwhelming the person who lives with the disease or the care team?
I'd like to rely on the upfront evaluation and diagnosis, and I put particular emphasis on the pre-diagnosis state of that patient. Tell me how you felt before this new rheumatic set of symptoms developed. I was golfing twice a week and taking walks with my partner or the dog and gardening, etc., versus the patient who, was already hobbled by osteoarthritis and maybe suffering from non-articular forms of rheumatism, fibromyalgia, pain amplification, chronic headaches, or other pain disorders. Knowing the patient is extremely important in this disease because so much of it is driven by history.
Great. Thanks, Len. This is truly a fascinating discussion. Jeff, any thoughts on that?
Yeah, no, I would echo those same things, and I agree. Your pre-disease state and identifying, what's going on with the patient before this disease and are there concomitant conditions. So Len mentioned giant cell arteritis that has its own very specific and important and sometimes organ-threatening manifestations. People can also have overlap with later onset or what used to be called elderly onset rheumatoid arthritis. Nobody likes elderly anymore. So later onset rheumatoid arthritis that has some peripheral manifestations. So I think it's helpful to recognize that there can be some legitimate overlap between PMR and some of these other conditions that I just mentioned that may or may not affect treatment if they had, say, concomitant rheumatoid arthritis with a lot of inflammation in their peripheral joints. But I think the pre-diagnosis, as Len said, is very helpful.
Yeah, I just would also add, I think that monitoring patients who, you can't get off of glucocorticoids, who have persistent and particularly new onset or different rheumatic complaints during that clinical course, I think those are the patients that really need to see rheumatologists, because these can be very complicated differential diagnoses. This is not common, but, it is seen, more than we would like to.
Yeah, this is truly fascinating. And I myself have learned so much in this discussion. Unfortunately, we have time for just one more question. And, we've been sort of talking about, and the overarching theme of this discussion has been surveillance and tools that can help surveillance. I now want to move to a more system level question. So, when new surveillance tools or PRO measures become available to clinicians, what would you say is the best way to get them adopted and integrated quickly, especially into everyday primary care practice?
Well, I think any system change getting easily adopted in primary care or specialty settings for that matter is a Herculean task that is very challenging because you're talking about changing infrastructure elements of the healthcare system. Some of the work that Len mentioned that he does at his institution and I do at mine, where you're collecting PRO data at visits or between visits, perhaps through the patient portal or on an app, I think that can be a helpful adjunct. Certainly, the Patient Spot app that Global Healthy Living Foundation has in some of their digital health resources, I think, can be very helpful. Those are things that patients can track on their own and then share with their doctor. I've certainly had multiple conversations spurred by patients essentially giving me their app-based data, what is more or less an electronic diary. That can be very helpful, and I think a useful complement as to what can be monitored over time, even without sophisticated computer or technology systems, but even using apps that patients can measure on their own.
Great. Thanks, Dr. Curtis. Great segue there. We've been spending time in this session exploring the physician perspective on PMR surveillance, what's working, what's not, what could change. But equally important, if not more, is hearing from those living with PMR and the clinicians who care for them. So if you're a patient or if you treat people with PMR, we invite you to take a brief poll to share your insights and experiences so we can build a fuller picture of the challenges and opportunities in the space. The link is currently displayed on the screen here, but we'll also send it to all registered attendees by email in just a few minutes. Thank you in advance for taking that poll. This has been a truly thoughtful and timely conversation. I cannot thank you enough, Jeff and Len, for helping us make sense of this topic and for providing such insightful points. What we know about PMR, what we don't, and what we really need to do better. Now, as we wrap up, a few key takeaways and recommendations for our audience. First, better surveillance in PMR starts with increased awareness that diagnosis is just the beginning. Ongoing tracking, especially during glucocorticoid tapering, is essential. Second, we need pragmatic tools that work in both specialty and primary care settings, whether it's validated PROs, structured clinical templates, or decision support systems. Third, partnerships between rheumatologists, PCPs, and public health professionals can help ensure patients don't fall through the cracks. And finally, and most importantly, listening to the patient voice, how they feel, what they're experiencing. That should be central to any surveillance strategy. There's, of course, many other takeaways, but we'll have to stop at that. Thank you again for joining us. We hope this discussion sparks new ideas and helps move us a little bit closer to a more informed, coordinated approach to PMR care. Dr. Curtis and Dr. Calabrese, thank you so much for sharing your thoughts and insights on this topic. And thank you for sparing us your time and joining us today for this webinar.
It's a pleasure to be with you today.
Absolutely.